Hi, my name is Maxime BATTISTELLA. I'm a full professor of pathology, dermatologist and pathologist in Hôpital Saint-Louis, Paris, France. I will talk to you today about sclerosing diseases of the skin. Here are my conflicts of interest. First of all, let's see what's the definition of sclerosis according to the French Academy of Medicine. It is the pathologic induration of a tissue due to fibrosis with excessive formation of collagen at the microscopic level. And you can see here at the left, it's the difficulty to pinch the skin with hard, stiff skin. Fibrosis is a non-specific lesion characterized by connective tissue hyperplasia, fibrous proliferation, and increasing collagen or elastic fiber synthesis. This is a microscopic definition and it corresponds macroscopically to the sclerosis. But when you use the word fibrosis or sclerosis, they are often confounded. In this first part of the talk, we'll see the diagnostic approach and mechanisms of sclerosing diseases of the skin. How should you approach diagnostically a person with stiff skin or sclerosis? Of course, you should have a look at the topography of the lesions. Are they diffuse, multiple, isolated? Do they involve acral skin, face, or trunk? What are the associated skin findings? Ulcerations, calcinosis, telangiectasia, Raynaud phenomenon, dyschromia, and very often you will have to perform a skin biopsy to help you for the diagnosis. Of course, the systemic involvement will help you to make the diagnosis among the sclerosing disease of the skin, especially if there is a lung, digestive tract, heart, or kidney involvement. You must, of course, know what is the clinical background of the patient. Is the sclerosis congenital or acquired? Do the patient have exposure to pro-fibrotic toxic or drugs? Is there any monoclonal gammopathy, diabetes, radiotherapy, or allogeneic hematopoietic stem cell transplant? What are the underlying mechanisms of stiff skin that will lead to clinical sclerosis? Most of all, fibrosis, which leads to thickening and densification of the dermis and sometimes of the subcutaneous tissue. But also, you can find sometimes edema, mucin deposits, amyloid deposits, and cell proliferation that will lead to this sensation of stiff skin. Fibrosis, of course, is mainly involved in systemic sclerosis, in Morphea, in sclerodermatous GVHD, and also in eosinophilic fasciitis or Schulman fasciitis. In these fasciitis, the sclerosis is deep. It involves the subcutaneous tissue and the fascia and leads to this peau d'orange aspect clinically. Fibrosis is also involved in lipodermatosclerosis in this patient with venous insufficiency with this inflammatory and sclerous plaques, which have under the microscope a very important sclerosis and fibrosis of the subcutaneous tissue. Edema is involved in sensation of stiff skin in patients with angioedema and in patients with chronic lymphedema. Mucin deposits are particularly involved in sclerodermoid features in two diseases. The first one is Scleramix Edema. When it was first described by Dubreuil in 1906, he gave this definition of the skin as hard, thick, and giving the impression of scleroderma. Indeed, sclerodermoid features are very frequent in these patients with Scleramix edema. It is related to the mucin deposits in the dermis, you can see here with the Alcian blue, but also with fibrosis and fibroblast proliferation. Here is a nice overview of everything that can be found in Scleramix edema. Everything is related to the monoclonal gammopathy that will stimulate the fibroblasts, that will increase the mucin deposits, the fibroblast proliferation, and at final step, the fibrosis. You've got this lonin facies, sharpest sign, downward sign, but also micropapules in the skin folds. Scleroderma of Buschke is the second disease where you will find sclerosis of the skin with mucin deposits. It's typically involved in the nuca area and in the back, and it's a descending fibrosis with erythema. There is classically three types of scleroderma: type 1 that is post-infectious, type 2 that is linked to paraproteinemia, and type 3 that is linked to diabetes. You will be able to make the diagnosis under the microscope: differential diagnosis with Scleramix Edema and differential diagnosis with Scleroderma, because the fibrosis is said to be fenestrated with mucin deposits all along the dermis. Amyloid deposits can be involved in stiff skin lesions. It's rare, but you can find sometimes amyloid plaques that are sclerodermic, and here you can see the deposits that are positive with Congo red. Finally, cell proliferation can lead to a skin lesion that is indurated. This is mostly the case in the UV-exposed areas for epithelial tumors with sclerosing stroma, most of all Morphea from BCC. And when you've got a sclerous plaques on the face, you must first of all think to that. But also you can find one localized sclerous lesions in connective tumors of the skin. And this is the case for dermatofibrosarcoma protuberans, as you can see here on the right. Let's have a closer look to Morphea and systemic sclerosis. Systemic sclerosis is an autoimmune chronic fibrosing disease which involves the skin but also deep organs. It's very rare with female predominance, and there are classically two types: a limited form, which involves the hands, the foot and the face sometimes, and a more diffuse form that is associated with much more deeper and systemic involvement. The skin lesions are very classical, with this very typical hands and legs and face, and most of the time you won't need any biopsy to make the diagnosis. As you can see here on the left, the criteria for the diagnosis of systemic sclerosis are mostly clinical and don't involve any biopsy criteria. And of course, you will be helped by the presence of an autoantibody as one of them, as described in this table on the right. If a biopsy is performed, what you will see is a fibrosis that is very dense, involving all the dermis, with neocollagen in the deep dermis, with horizontalization of the dermis subcutis junction. And also one very important feature is the disappearance of the fat cells around the sweat glands, and the sweat glands are like elevated in the dermis. Morphea, or localized scleroderma, is a spectrum of fibrosing cutaneous disorders which have no systemic involvement. It's also very rare. It's also mostly female predominance. And here the association is with genital lichen sclerosis or autoimmune disorders. And there is no evolution of the Morphea to systemic sclerosis. They are two different diseases. Classically, Morphea is one plaque or more plaques with a center that is white, sclerous, and a lilac ring all around. But there are also forms that are more linear, as here you can see on the right on the face. There is a bunch of subtypes of Morphea. We can classify them in 5 main types: the limited type, the general type with 4 or more plaques over 2 or more anatomical sites, the linear types, the deep type of Morphea that can involve the subcutaneous tissue but also the fascia, the muscle, the bone, and the eosinophilic fasciitis or Schulman syndrome. Most authors now consider these eosinophilic fasciitis as a variant of Morphea involving the fascia, with the presence sometimes of eosinophils under the microscope. Morphea. What will it look like under the microscope? When you perform the biopsy in the center, in the sclerosis center, you will find an image that is very close to systemic sclerosis. It is fibrosis of the entire dermis, horizontalization of the dermis subcutis junction, and ascension of the sweat glands, with very poor inflammatory infiltrates when you biopsy in the center. Recently, generalized morphea have been divided in two clinical subtypes, isomorphic and symmetric. By computer-assisted image analysis, isomorphic type have been defined as lesions involving mainly the friction areas of the brassiere, of the waistband, of the inguinal folds. The lesions are here more superficial, and there is more frequently a genital lichen sclerosis. Whereas in the symmetric type, the legs and arms are much more involved, there is deeper fibrosis, and it may be associated with more autoimmunity. Here is an example of isomorphic generalized morphea. You can see this superficially sclerous, brassiere, band localized sclerosis, and in this patient, and you will find it in the majority of patients with this generalized isomorphic morphea, there was a lichen sclerosis, genital lichen sclerosis, that manifests initially mostly by this depigmentation and sometimes by a very slight atrophic epidermis. This leads me to this part when I will talk about the sclerosing diseases of the skin when they are not clinically sclerous. These are the clinical early or unusual forms of Morphea, systemic sclerosis, or GVHD in the pre-fibrotic inflammatory phase, in edematous forms of this inflammatory phase, and in superficial atrophic forms. First of all, these superficial atrophic forms of Morphea that are sometimes considered as a variant of cutaneous lichen sclerosis. Indeed, under the microscope, the lichen sclerosis is mostly made of epidermis atrophy, whereas there is only a slight fibrosis of the superficial dermis. This sclerosis of the superficial dermis is not sufficient to induce a clinical sclerosis. Rather, you will see this sensation of atrophy, of epidermal atrophy, and of whitening of the skin. Another form of superficial morphea, when you will not palpate really a stiff skin, is Scleroderma pierini-pasini, which is characterized by these plaques that are slightly pigmented, atrophic, with depression of the plaque. The second form of non-sclerous morphea is the pre-fibrotic morphea inflammatory phase. Here are two examples of these red macules, rounded, with a sort of lilac rig in the first one. When you biopsy such early morphea, you will find an inflammatory infiltrate in the dermis made of lymphocytes and of some plasma cells that is interstitially disposed, with very few sclerosis. And here the differential diagnosis is very important because it must be made with borreliosis, interstitial granuloma annulare, interstitial granulomatous dermatitis, interstitial mycosis fungoides, and interstitial cutaneous metastasis. Here are some examples of these differential diagnoses. Most of them will be made by the skin biopsy, but in such cases as borreliosis, you will sometimes need serologic tests to differentiate it from initial morphea. Edema can be the manifestation of the initial phase of systemic sclerosis, morphea, and chronic GVHD. You know well the sensation of puffy fingers in systemic sclerosis, but edema is also a manifestation, an early manifestation of eosinophilic fasciitis and sometimes of chronic GVHD and morphea. This is due to the fact that in these diseases, the first thing to happen is vascular inflammation and vascular leakage, with fluid extravasation out of the vessel and inflammation, and afterwards the fibrosis. So it's the manifestation of the disease before the fibrosis happens. Finally, there is a lot of other sclerosing disorders of the skin that can be separated in 4 categories: toxic sclerosing diseases due to toxic oil, professional exposure, mild eosinophilia syndrome, toxic or drug-induced sclerosis, with many of them due to chemotherapy, nephrogenic systemic fibrosis due to high-risk gadolinium in patients with chronic renal insufficiency, the sclerosing diseases associated with monoclonal immunoglobulin, such as PUMS syndrome and ASOP, a bunch of diverse sclerosing disorders, including carcinoid syndrome, porphyrias, diabetes with arthropathy and radiodermatitis, and also in childhood, the genodermatosis with sclerosis, skin sclerosis, such as stiff skin syndrome, premature aging syndrome, phenylketonuria, or H syndrome. Just as an illustration of some of these entities, here is an example of sclerosis with pemetrexed, a chemotherapy. It's very typical. You will have these first inflammation of the legs followed by sclerosis of the legs. Another example is the skin sclerosis that can be diffuse associated with PUMS, in addition to the vascular proliferation, skin vascular proliferation, that are very typical for this syndrome. Finally, what are the key messages in sclerosing diseases of the skin? You must keep in mind that sclerosis may be due to fibrosis, of course, but also to mucin, edema, amyloid, or cell proliferation in the skin. You must have a look at the disposition and topography of the sclerosis to help you with the diagnosis, and of course often to the skin biopsy. Keep in mind that systemic sclerosis and Morphea are 2 different diseases, but can have very close histology when you biopsy them at the stage of sclerosis. Morphea can have a pre-fibrotic inflammatory edematous phase with polyfibrotic superficial forms, and here there is a bunch of differential diagnosis. And finally, keep in mind the many entities and categories of diseases that can have skin sclerosis: toxic drug exposure, monoclonal immunoglobulin associated, genodermatosis, and of course, when you've got a localized sclerosis, tumors. To help you going further, here are main references in the field about the guidelines on the diagnosis of treatment of sclerosing diseases of the skin, published in 2017 in the GAADV, and one nice review of Scleroderma-like disorders in Revue de Médecine Interne. I thank you, and I thank my colleagues in the Dermatology and Pathology department that helped me with the figures of this presentation. Thank you.